All right, everyone. This is Dr. Manish Chhabra, your ophthalmology educator, and today my heart is very, very full of gratitude towards all of you, due to which I am able to come up with my own ophthalmology teaching platform, which is EyeCoach Dr. Manish Chhabra teaching app, with a vision that I want to make this app this one-stop resource for all your ophthalmology needs. And I'm very, very glad and thankful to all of you for your constant support and the constructive feedbacks that I have received over the period of my teaching ophthalmology in last 10 years. So as you always say, one teach, two learn, TO, to learn, and one teach, two learn, TWO, to learn. है ना? And guys, this app in the initial phases will be available on Android. The iOS version of this app is under process and will be available soon, and I'll personally notify all of you in my Telegram group Ophthalmology by Dr. Manish Chhabra, and so that you are able to download the app, but for some time it will be available only on Android. Okay, so there is going to be the regular course for NEETPG, INICET, MBBS prof students. There will be a regular course for foreign medical graduate exam students. There will be a test and discussion, and as we will proceed forward, so I'll be coming up with more courses, short courses, and all that stuff. Of course, after taking your active feedbacks, I have specifically included a question bank which consists of the PYQs, the PYTs, and many new questions. I am also in a process of making an image-based question bank, which I'll be coming up with very soon, right? And of course, I'll always be available for your feedbacks. So any feedback you would want me to know, please convey me on this number. This is my personal number, which I am sharing it with all of you today. So please let me know if there is something that you want to convey, or you want me to do some specific short course, or you want me to add some specific video, or you want me to put some specific pattern of MCQs. Yes, so I'll be needing your support. Please support me like you have always supported me in last 10 years of my ophthalmology teaching, and it will be my commitment to take you from basics. I'll teach you basics, and slowly and steadily we'll move together towards brilliance, right? Okay, so now I'm going to discuss the previous year questions which I have taken from last 3 to 4 years of NEETPG, INICET, and FMGE exam. And what I have done is, sometimes there is the same question which gets repeated with a few changed options. So I have eliminated those questions. So I have kept one question only. Okay. So now in total, this file has 113 questions. And of course, you may find a question on a particular topic maybe 2 or 3 times as well, but only those questions have been repeated which I feel that you need to understand the different concepts. Otherwise, my idea is to take one question, right? If there are 3-4 questions on a one topic, take one common question which is covering all the relevant 2-3 more questions, and then put it here so that we can discuss it accordingly. So I want to make this PYQ session the last resource for you for revision during nth hour. Yes, so without wasting any more time, we can start with it. A 3-month-old child with mucus coming from the eye on pressing the inner corner, and there is watering. What will be the treatment of this condition? Now this is a case of what? Congenital lacrimal duct obstruction, है ना? That is why on pressing the mucus is coming out, regurgitation test is positive, which will eventually lead to congenital dacryocystitis. Okay, now what will be the treatment of choice? Now, if the patient has come to you, of course, the patient will be coming along with his or her mother. So for first 3 months, you go for simply massage, because the most common cause of congenital nasolacrimal duct obstruction is your imperforate valve of Hessner, or there is a membranous occlusion over the valve of Hessner. Yes, first. Second is your foreign body. Foreign body, it may be a small sand particle which clogs the nasolacrimal duct. So when you will do massage, so you are going to push the tears through the nasolacrimal duct, or it will tear away the membranous occlusion at the distal end of the nasolacrimal duct. Okay, so the answer will be your simply lacrimal massage. What is the name of this massage? That is very important. There was one question on this as well. You call it as Krigler's massage. Krigler's massage, but you do it for 3 months. If it is not controlled, then what do? You go for syringing. And mind you, when you are going to give massage or syringing, you always add on an antibiotic. Antibiotic most commonly used is Tobastar, because that is believed to be relatively safe in children. If after 3 months, again 3 months, there is no resolution, you go for probing. So what is probing? Probing, these are the Bowman's probes. क्या बोलते हैं इसको? सिलाई बोलते हैं. Bowman's probes. You pass it from the puncta to canaliculus to nasolacrimal sac to nasolacrimal duct, and you pierce away the membranous occlusion. That is your Bowman's probe. And lastly, you can go on for DCR, but after 4 years of age. So this is about the entire treatment of nasolacrimal duct obstruction, which will eventually lead to congenital dacryocystitis. Okay, all right. Now, a person with jaundice and tremors is showing the following finding in the eye. What is the diagnosis? Can you appreciate? This is your golden brown ring. This is your golden brown ring, and this ring is typically known as KF ring. What is KF ring, boys and girls? This is your Kayser-Fleischer ring. And what happens? What is the source of this ring? There is deposition of copper in the, there is a copper deposit in the Descemet's membrane periphery. Descemet's membrane is one of the layers of the cornea. At the periphery, there is copper deposition, and most commonly it is seen in liver conditions like Wilson's disease. Okay, but I want to tell you 2-3 extra points about Wilson's disease, because there were 2-3 more questions which was asked on Wilson's disease, but there was different option. Okay, now there is involvement of the gene which is ATP7B gene, which lies on chromosome 13. Unlucky chromosome. On chromosome 13 there is RB gene, retinoblastoma gene as well, and Wilson disease gene as well. Okay, ATP7B. Now what happens is, in Wilson's disease there is decreased serum ceruloplasmin. Do you know what is ceruloplasmin? Ceruloplasmin is copper binding protein. When there is decreased ceruloplasmin, so that actually tells me that there will be decreased bound copper. There will be decreased bound copper, because ceruloplasmin carries copper, and copper is nearly 90% bound to ceruloplasmin. But when there is ceruloplasmin which is less, the bound copper will be less. Because there is less boundation of copper, there is increased copper, because free copper is available, increased copper in urine. Okay, increased copper in urine is there, and there is deposition of the copper in different organs. Deposition in organs. Now please remember, increased copper in urine, decreased serum ceruloplasmin, and decreased serum copper. So very important. All right, but answer, you know the answer is Wilson's disease, KF ring. Don't confuse, boys and girls, KF ring with that of Fleischer ring. Now you'll say, sir, what is Fleischer ring? Fleischer ring is iron deposition on the epithelium of the cornea, and it is seen in which disease? Keratoconus. Keratoconus is a disease in which there is increased curvature of the central part of the cornea. You say corneal ectasia, ectatic position situation in which there is bulging of the central cornea like this. This is the normal cornea. So this is corneal ectasia in the center. Okay, that is Fleischer ring, and it is iron deposition. KF ring, copper deposition. Descemet's membrane. Fleischer ring, it is epithelium which is involved. Okay, and when there is presence of KF ring, mind you that this KF ring is reversible. So when I say it is reversible, I can also say that it tells you the response to therapy. क्या पता लगेगा? Response to therapy, if the parent means if the patient is responding well to the treatment, the KF ring will get reversed. The KF ring will absolutely go off. Okay. All right. A child with a history of malnutrition is examined and the following image is seen. What is the most likely diagnosis? Now, can you appreciate that there is bulging? So this was a very tricky question. So some students, they said that, sir, history and the image was not matching at all, right? So there is bulging with uveal tissue incarcerated posteriorly. So of course this is anterior staphyloma. Okay, I believe it. But you will say, sir, is it going well with that of the history of malnutrition? Let's connect the dots. First, megalocornea. What is megalocornea? When the corneal diameter is more than equal to 13 millimeter. It is just the megalocornea, but here you can appreciate that there is bulging along with the uveal tissue incarceration. Just remove this option. Boophthalmos. Boophthalmos is increase the axial length of the eyeball. There will be hazy cornea. There will be bulging eyes like that of cow. Bull's eye. Hai na? Boophthalmos. So this is also not there, and it does not go well with the history of malnutrition because it is seen in congenital glaucoma. There should be history of raised intraocular pressure, which is not given in this patient. What is corneal degeneration? Of course, there are dystrophies and degeneration of the cornea like arcus senilis, spheroidal degeneration, band-shaped keratopathy. Of course, based on the image, this is clearly eliminated. Answer is anterior staphyloma. But now let me connect the dots for you. So if there is malnutrition, let's say the patient is having vitamin A deficiency. So when there is vitamin A deficiency, there will be conjunctival xerosis. There will also be corneal xerosis. When there is prolonged corneal xerosis, it will lead to the drying of the cornea, as a result of which the cornea is going to develop inflammation. You call it as keratitis. When there will be inflammation which will be prolonged, it will lead to development of corneal ulcer. The sequelae of corneal ulcer is desmatocele, corneal perforation, pseudocornea. Yes, when there will be corneal perforation, so there will be pseudocornea formation over the surface of the cornea with the iris tissue, because whenever there is perforation, there will be sudden deflation of the eyeball. As a result, the iris will move anteriorly and will plug the small defect which is created as the result of perforation, and there will be re-epithelialization of the defect. Now the epithelium layer along with the iris which is incarcerated posteriorly, it will bulge. And this is what you call as anterior staphyloma. So I hope now you are able to connect the dots. So this is, boys and girls, your anterior staphyloma. Okay. Okay. A young male complains of rhinorrhea, watery eyes and itching. That means the patient is having allergy. Okay. The clinical image is provided. What is the diagnosis? Can you appreciate that there are big papillae? These papillae are cobblestone papillae, and typical history is young male. It is more common in males who are teenagers, and this is actually the disease which is vernal keratoconjunctivitis. Now let's do vernal keratoconjunctivitis. Let's talk about the clinical features. So it is more common in males It is a bilateral condition. It is type 1 plus type 4 hypersensitivity. If this is not in the option, go for type 1. If this is not in the option, go for type 4 hypersensitivity. Of course, it is more common in summers, but it is not known as summer catarrh. It is known as spring catarrh, and you typically see cobblestone papillae. What are the other features? There is shield ulcer which may be present. There is pseudogerontoxon. Pseudogerontoxon is peripheral corneal opacity in the form of a bow. Bow समझते हो? Bow, तीर कमान, bow and arrow, bow. So pseudogerontoxon. There is Maxwell-Lyon sign. Maxwell-Lyon sign is thick ropey discharge with eosinophils. It is thick ropey discharge. So these are all your features seen in vernal keratoconjunctivitis with eosinophils. Okay, and what can be the sequelae? Due to constantly rubbing of the eyes, it can lead to formation of keratoconus. Very, very important, keratoconus. Okay, so the treatment that you are going to give is new generation antihistaminics, which is olopatadine. If olopatadine is not in the option, go for sodium chromoglycate. You know, sodium chromoglycate is your mast cell stabilizer. It is mast cell stabilizer. But if I may ask you, what is the drug of choice? What will be the drug of choice? Drug of choice will be your olopatadine. Okay, all right. Now coming over to what is the treatment of choice in recurrent pterygium. So what is pterygium? First and foremost, I am going to show you a very crisp video so that you are able to connect the dots. So this is actually the best treatment that we do for pterygium. Okay, so check this out. So as you can see, pterygium is a wing-like fold which is coming from the nasal side. So guys, what I can do is one thing, I can make you write everything which I am speaking. Second is, because this is a PYQ revision session, I believe that you have already gone through my main notes and you are sitting here after going through my main notes. So I'll be telling you main points, and also any video that I'm going to show to you, I'll be doing a voiceover right in front of you so that you are able to pick up everything quickly. Okay, so there is a wing shaped fold which is coming from the nasal side. Mind you, pterygium is more common on the nasal side. Okay, so what are the surgeries that you can go? You can simply excise this wing like fold. So because you will excise it, so the underlying sclera will be left bare. You call it as bare sclera technique. This is one thing. Second is, you remove it and you take the same dimensions of the conjunctiva from the same eye from the temporal side and you put it on the nasal side. So what is the benefit? If you will leave the sclera bare, there are high chances of recurrence, which is nearly 80 to 85%. Yes, but if you will cover it with the help of the conjunctival graft which you have taken from the temporal side, it will prevent the recurrence of pterygium. Okay, so I think you have seen this. So on removing this is the bare sclera technique. If you will do it like this, that's also okay, but 80% of the chances the patient will come to you for resurgery, hai na? Okay, so now the defect is measured and the same conjunctiva is taken from the temporal side and put on the nasal side. It reduces the recurrence rate to 0.01%. Mind you, so this is perfect surgery. What is perfect? Perfect is pterygium extended resection followed by extended conjunctival transplant first. Or some doctors say that instead of taking a graft from the temporal side, you simply put mitomycin 0.02% dipped sponges onto the nasal side for 2 minutes and then wash it off. So it is going to kill the fibroblasts. So it will prevent recurrence. But the best treatment remains autograft. So here you can appreciate that it is put and some glue is put. Glue means, of course, Fevikwik 5 रुपए की मत ले आना डालने के लिए. There is a fibrin grade, medical grade glue which is used for pasting the graft on the bare sclera. Okay, So surgery is completed. I hope it is understandable, and this is your best surgery of choice. So treatment of mitomycin C. What do you do in treatment of mitomycin C? You have 0.02% for 2 minutes. Conjunctival autograft, here recurrence rate is 0.01%. So best surgical excision is your Bayer-Sclera technique. Bayer-Sclera technique, but 80% there is a recurrence. Now since we are doing pterygium, let's make a box. I am going to give you 2-3 important other MCQs which are asked on this topic. So if we talk about the grading, so there is grade 1, 2 and 3. In grade 1, when the pterygium is 0 to 2 millimeter on cornea, here 2 to 4 millimeter means from the limbus. I am telling you distance from limbus. Here more than 4 millimeter distance from the limbus. This is the grading of pterygium. Now please make another box. So what is the cause of loss of, what is the cause of diplopia? What is the cause of diplopia in pterygium? One is your astigmatism. Now if I talk about astigmatism, you saw a pterygium coming from the nasal side. So what happens is the vertical curvature of the cornea is more than horizontal curvature. Yes, that is why you call it as with the rule astigmatism. Now what happens is, because of the pterygium which is coming from the nasal side, as it will run across the x-axis, it is further going to flattening the x-axis. So there will be with the rule astigmatism because of excessive flattening of the x-axis, because it flattens along the axis with the rule. Second cause of diplopia is mechanical restriction. If there is pterygium which is coming from the nasal side, it will hold the eyeball, and when you try to abduct the eye, this eye will not go out but this eye will go in. So there will be double vision. So mechanical restriction. These are the causes of diplopia, mechanical restriction. Another important point I want to tell you is pterygium has the ability to go deep into the cornea. So it can go in anterior stroma. Anterior stroma invasion. Anterior stroma invasion. Only anterior stroma. It does not go till Descemet's membrane, till epithelium. And what is the most common etiology? These are all one-liner options in your previous year MCQ. So I have taken one important question. I am telling you all the relevant options. Yes. So most common etiology is not IR, infrared rays. It is UV rays. UV rays. Okay. So these are all your previous year questions. Done. Okay. Now coming over to a patient with a vision of less than 3/60 but more than 1/60 in his better eye. Which type of blindness does he have? So blindness, if we talk about blindness, recently INICET May 2025 paper also happened, in which they had asked about the definition of blindness. Let me tell you, it is also repeated in your FMG multiple times. Now it is visual acuity less than 3/60 in better eye. In better eye. Now two things. One, with best possible correction, means glasses. With best possible correction. And second is just the presenting visual acuity, means the patient has come to you, just ask the patient to close the eye and read the letters on the Snellen chart. That is presenting. But if you start to correct the refractive error by putting glasses, that is your with best possible correction. Yes, if they have specifically asked with best possible correction, this is your WHO criteria. If they specifically asked as per NPCB, mind you, NPCB is now NPCB VI, National Program for Control of Blindness and Visual Impairment. For that, it is presenting visual acuity. That is your definition of blindness. Visual acuity less than 3/60, or if visual acuity is not given, visual field less than 10 degree. This is one and the same thing. Okay. If any of these two is present in a patient with best or presenting, based on which you will mark. Okay. Now coming on to this specific criteria. So what happens is, if the patient's vision is 6/18 to 6/60, you call it as low vision. If the vision is 6/60 to 3/60, you call it as economic blindness. If the vision is 3/60 means less than 3/60 to 1/60, you call it as social blindness. If it is less than 1/60, you call it as manifest blindness. If it is PL, perception of light is gone, yes, you call it as absolute blindness. Got it? Now they have asked about less than 3/60 to 1/60, so automatically the answer is social blindness. Got it? Okay. Now, a farmer is hit by a leaf or vegetative matter in his eye few days back. He visits eye OPD with pain, photophobia. So typical organic matter injury. Whenever there is organic matter injury and farmer by occupation, so there is pain, photophobia. It goes more in favor of an ulcer of the cornea, which will be viral. No. Bacterial? Not at all. Fungal? Absolutely correct. It will be fungal keratitis. Now mind you, herpes simplex keratitis, you will typically see dendrites. There are typically dendrites on the cornea on fluorescein staining. Okay. Acanthamoeba keratitis is typically seen in contact lens users. Mind you, you will not stop here. If I ask you which is the most common organism associated with keratitis in contact lens users, you will go on for Pseudomonas. But if I ask you which is the most common organism associated with contact lens users who have a history of swimming in pond, or history of washing contact lens with tap water, then you will think of none other than acanthamoeba. But in acanthamoeba, what happens is, see, there are two things. One, signs are more than symptoms. Another is symptoms are more than signs. Here, symptoms are more than signs because it is very painful. And this is just small ring-shaped ulcer. It is very painful, while herpes simplex keratitis is signs more than symptoms. Okay. Now, oh, sorry. While fungal keratitis is sign more than symptoms. Okay. All right. Now, what are the other features of fungal keratitis? So there is a dry looking ulcer with fluffy margins. These are all your previous year keywords. Fluffy margins. What else? There is presence of satellite lesions. Okay. Satellite lesions are there. There is hypopyon. This hypopyon will be fixed. It will be fixed and it will be sterile or non-sterile. It will be fixed and non-sterile. There is typical Wesley's immune ring. Now mind you, Wesley's immune ring is the antigen antibody reaction which is happening between normal cornea and the infected cornea junction. Yes. Okay. And it is because of the patient's own antibodies which are trying to control the spread of the antigen from the pathogen. Okay. Wesley's immune ring. It can also be seen in viral keratitis. Okay. All right. So this is about your fungal keratitis. Now, of course, conjunctival congestion, watering, photophobia, loss of vision, it will be there. है ना? These are the features that you have in fungal keratitis. So what will be the treatment of fungal keratitis? If we are talking of branched fungus, अगर मैं branched fungus की बात कर रहा हूं तो it will be natamycin. If I am talking of unbranched fungus, it will be nystatin. Okay. And new generation antifungal is voriconazole. New generation antifungus is voriconazole. Okay. All right. And bacterial keratitis, can you tell me the most common organism causing bacterial keratitis? बता पाएंगे? It is Staph aureus bacterial corneal ulcer. It is Staph aureus, Staph epidermidis. These are the most common organism. But most common conjunctival bacteria commensal. This is also your previous year question. That is your Staph epidermidis. It is Staph epidermidis, mind you. Okay, all right. Now next is, so I hope you have got the answer, right? Okay, now next is a girl with ptosis. When eats food and sips fluid, her ptosis is decreased. What is that? So let me show you one very interesting video. I am sure that you would not have seen it before if you have not attended my class, of course. So what is this? We are talking of this condition. Can you appreciate something is happening in one of the eyes? देखो, देख पा रहे हो? What is this? Okay, I hope you are able to appreciate it. So on moving the jaw left and right, there was moving of the upper lid because of synkinesis. What is synkinesis? Sometimes there is misdirection of the fibers which are supplying the lateral pterygoid muscle, and you know the sideward movement of the jaw is due to lateral pterygoid contraction. Yes, so when there is lateral pterygoid stimulation, the same nerve which is supplying the lateral pterygoid, this nerve also supplies the levator palpebrae superioris. So along with the lateral pterygoid muscle contraction, there is simultaneous contraction of the levator palpebrae superioris, and there is misdirection. It may happen maybe after a surgery, any surgery which was done of facial region, and there is synkinesis, and this is your complicated ptosis. Mechanical ptosis, if we talk about, it is due to paralysis of levator palpebrae superioris. So there is mechanical falling of the upper eyelid. There can be third cranial nerve palsy, or there can even be Horner syndrome leading to mechanical ptosis. Mechanical is when there is a lid tumor which is large. So large lid tumor is going, due to gravity, it is going to take the upper lid down. Sorry, large lid tumor, upper lid, so that the lid will become heavy and will fall down. Horner syndrome is neurological ptosis. Neurological ptosis is due to nerve involvement like sympathetic fibers. The another example of neurological ptosis is third cranial nerve palsy. And then there is blepharophimosis syndrome, BEP syndrome. So B for blepharophimosis. Blepharophimosis is small interpalpebral fissure, and E is epicanthus inversus, while P is ptosis. Okay, so blepharophimosis syndrome, of course this is not the answer. There is no movement of the upper eyelid with chewing. Okay, so the answer is complicated ptosis. I hope it is clear, and I hope I have explained you each option one by one. Which of the following technique is gold standard for measuring IOP? I always say in my class, go for gold. So that is a clear cut Goldman's applanation tonometer. But if we talk about Schiot's tonometer, this is your indentation tonometer. Which tonometer? Indentation tonometer, which does not give quite accurate value. And we have got tonopen, which is used for scarred or edematous cornea. And then there is pulsar tonometer. So there is one tonometry which is non-contact tonometer. Non-contact, because there is no contact, it just throws a pulse of air, and based on which it measures the IOP. And this non-contact is used for screening techniques. Because there is no contact now, so I am just going to show you a screening tonometer which is non-contact tonometer, so that you have an idea of how it is done. So this is your non-contact tonometer. Okay, check this out. So you will appreciate that the moment I am going to press the joystick, there will be a sudden appearance of the intraocular pressure. That is so quick. So we require a quick technique now, and also the same technique which does not require sterilization after every use. So here you can see 17 millimeter of mercury, and you will see that there is no contact between the nozzle and the
17 millimeter
patient.
of mercury, right?
Okay, so here can you appreciate So this is non-contact. But if I talk about Goldman applanation tonometer, to check this out. So Goldman applanation, what you do is you stain the eye with fluorescein dye and you look out for the appearance of two half semicircles. The moment the two semicircles inner edge just touch each other, you take the IOP reading. Whatever reading is there at the dial, you multiply it by 10 and you will get the gold standard IOP reading. Check this out what I am doing. This is fluorescein dye, which is orange in color. So this is proparacaine eye drops, because you need to touch the tonometer on the surface of the cornea to extinguish blink reflex. You will use proparacaine. Okay. Alright. So after doing this, the music is good, hai na? So you will examine the eye with blue light. So fluorescein dye is going to absorb the blue light. It is going to emit the green light. Okay. Alright. So fast forwarding, can you see the two semicircles? So their inner edges are just in touch with each other. So at that time I am going to measure the value at the dial. Okay. Alright. So you can see, what is this? What is the value? It is 0.8 na? 0.8 na? Just 0.2 less than 1. So you multiply it by 10. So it will become 8 millimeter of mercury. Okay. Alright. So this is your gold standard technique. This is your gold standard technique. Alright. Now coming on to a newborn child presents with watering photophobia. On examination, the following is seen. Can you appreciate the size of the eyeball is big? So it is large eyes. Large eyes, number one. So they have told watering photophobia, and there is another feature which is blepharospasm. So we are talking of one triad. This triad is that of congenital glaucoma. But the earliest feature, I repeat, the earliest feature is watering. Your previous year question. What are the other features of congenital glaucoma? There is bull's eye, boophthalmos. Boophthalmos is there because of the increased axial length due to raised intraocular pressure. There will be high myopia. There will be myopia because the lens of the newborn is very soft. There will be flattening of the lens, and also due to raised intraocular pressure, there can be subluxation or dislocation of the lens. Due to raised intraocular pressure, there may be subluxation or dislocation. There may be tears in the Descemet's membrane. You call it as Harb's striae. H for Harb's, H for horizontal tears. Horizontal tears in the Descemet's membrane. Mind you, don't confuse this with Vogt striae. Vogt striae is vertical tear or vertical stretch which may lead to tear in Descemet's membrane in keratoconus. These are known as Vogt striae. But this I am talking of Harb's striae. But when there is tears in the Descemet's membrane, it will lead to edema of the cornea, stroma, which will give a typical ground glass appearance. Ground glass appearance of the cornea. So cornea may become hazy. Now what will be the treatment? Surgery of choice is goniotomy. Surgery of choice is goniotomy. But when the cornea is hazy, you go for CTT, combined trabeculectomy and trabeculotomy. Okay, and make one chota sa more box. Which gene is associated with congenital glaucoma? CYP1B1. Now getting back to the question, so there is watering, there is photophobia in the newborn. So congenital cataract, why there will be watering, why there will be photophobia? There should be leukocoria, which is not mentioned. So you can appreciate that there is no leukocoria. It is actually the reflection of the torch light. So that is removed. In megalocornea, why there will be photophobia? Why there will be watering? Why there will be increased size of the eyeball? Okay, let's take, you could not actually make out the increased size of the eyeball, whether this is in megalocornea or congenital glaucoma, that's okay. But why there will be photophobia? Why there will be watering? So that is eliminated. In congenital dacryocystitis, of course, there can be photophobia, there can be watering, but can you see any swelling on the nasal side? No, there is no nasal canthal swelling. No nasal canthal swelling. Yes, so that also eliminates this. So the answer is your boophthalmos.